We're delighted today to have Dr. Mukaila Raji from the University of Texas Medical Branch at Galveston to be here with us. He is the professor and a division chief at UTMB. He's the director of the UTMB Geriatric Fellowship. He's with the Department of Internal Medicine and the Division of Geriatric Medicine. I can't imagine that we could ever get anyone who has more in-depth knowledge, and he has such an important topic today. It's something that concerns all of us, whether we're the older adult or we're caring for someone who is older and on multiple medications. So help me welcome Dr. Raji for bad drugs. It might not be dementia, it might be the medication.
Thank you for the excellent introduction. And I also want to thank the Elizabeth McGowan Training Institute, the Georgie Briscoe Resource Center, the Morningside Ministry Training Institute, and the Morningside Ministries for giving me this opportunity to talk about a very important topic in geriatric medicine. How do we prevent use of toxic drugs in the elderly population such that we can actually prevent falls and other adverse events of medicine? I hope at the end of this talk, we will all be able to recognize why seniors are prone to drug toxicity. We'll also be able to recognize and know the specific bad drugs that kill memory and have high potential to send seniors to the emergency room. Then we're going to describe what can we do practically. This is not a theoretical talk. This is about what can we do now to reduce drug poisoning and toxicity in the elderly population. Then I'm going to end the talk by emphasizing that the non-prescription medicine, the complementary and alternative drugs, can also cause as much damage as the prescribed medicine. So let's start with an example that I've seen over and over again in my clinic. But before I do that, I want to let you know why am I here? Why am I giving this talk? The reason is well explained on this slide. Medication errors and drug poisoning is very common. It occurs regularly in up to 59% of hospitalized patients. And studies upon studies have shown that drug toxicity is the number 4 leading cause of death, ahead of pulmonary disease, diabetes mellitus, AIDS, pneumonia, accident and motor vehicle injuries. It is potentially preventable. Indeed, studies have shown that almost a third, 31%, of all hospital admission in the elderly as a result of adverse drug events. So let's see a common example. An elderly man with urinary tract infection went to see his primary care doctor on a Friday. He's been doing well. He's taking his blood pressure medicine, enalapril, for 5 years. And then the doctor put him on antibiotics. Then on Monday, the patient was rushed to the emergency room for irregular heartbeat, serious dizziness, and hyperkalemia, which is high blood potassium. Because of the bad arrhythmias, cardiac arrhythmias, he was admitted to the intensive care unit. This is a potentially preventable admission. And as you can see here, there are many antibiotics you can use for infections. One of these was prescribed. It shouldn't be, given the fact that the patient is already on a particular medicine, and that is Bactrim. This is preventable if we have a system, whether by electronic medical system, that will stop the doctor from starting that medicine, given that the patients already have another medicine on board. Now, you say, why will ordinary antibiotics, why will it cause a problem with my blood pressure medicine? Now, I just give this example. For instance, we know that the content of this particular antibiotic, trimethoprim, is structurally and pharmacologically similar to potassium-sparing diuretic called amiloride. It's not a diuretic, but somehow it has that property of increasing potassium in your body by decreasing excretion of potassium. So when somebody on potassium increasing drug is given these antibiotics, there's a very high risk of the person developing high blood potassium. So this can be solved from the system point of view, as well from the angle of continuous medical education. Now, this is another study that was published this year. This is important, and a lot of studies are talking about this because, think about it, 31% of admission to hospital are due to preventable medication errors and adverse drug events. So a lot of people are looking into it. This is another study that was published just June 2010 in one of the premier journals, the Archives of Internal Medicine. When Bactrim, trimethoprim sulfamethoxazole, was used in conjunction with ACE inhibitors, there is a 7-fold increased risk of hyperkalemia-associated hospitalization. And no such risk was found with other common antibiotics like amoxicillin that you could have used for bladder infection. So this is a potentially preventable event, and this happens on a daily basis. And doctors and nurses and patients need to know this. Now, this is another study that was published, a little older study. It's published in the Journal of the American Medical Association. This study basically shows what are those drugs causing hospital admission for drug poisoning. So they look at hypoglycemia, which is very low blood sugar. There is a 6-fold increased risk in admission if these antibiotics called Bactrim is used in previous week in seniors already on glyburide. Glyburide is medicine for diabetes. Digoxin poisoning, a 12-fold increased risk if macrolide antibiotics that is called clarithromycin was used in previous week in those on chronic digoxin. Hyperkalemia, which is high blood potassium, 20-fold increased risk of being admitted for hyperkalemia if potassium-sparing diuretics was used within a week in patients already on chronic ACE inhibitors. This may be a very technical example, but I use this specifically to illustrate that we can create systems to prevent this kind of admission due to drug poisoning. Now, this happens to young, middle-aged, and elderly population. But seniors are much more prone to being admitted for drug toxicity. The question is, why? There are several reasons, but the top 3 reasons are what I listed on these slides. As we get older, we're unable to eliminate drugs quickly. We tend to be on too many drugs. And sometimes we are just on plain bad drugs. There's no other way of calling it, or very high-risk drugs. So I'm going to go through the next slide to tell you what I mean by this slide. For instance, most drugs are broken down by the liver or kidney and eliminated. But as we get older, the kidney and liver function decrease with aging. So older adults are not able to remove this drug as quickly as younger adults. So drug at normal young adult dose can easily accumulate in older people and result in toxicity. So part of the things we do in geriatric medicine is to know that we need to start seniors when they need medication on a low dose. and